Good morning, Chairman, Co-Chairman, Professor Frankie, Professor Suthorn. I would like to begin this section with the case discussion, the complex humerus fractures. May I have a slide, please? Thank you. So the case will be the 54-year-old woman sustained the left shoulder pain after she fall down on her left shoulders. The past history, she has histories of ovarian cancer, but already complete treat, and she also treat with the osteoporosis in other hospital. The primary survey is normal. There is no serious associated injury. On the affected part, it shows that she had swelling and tender with ecchymosis on her left shoulders. There is no open wound, and the neurovascular status was all intact. This is the investigation. The plain radiograph. So you can see that there is a proximal humerus fractures, and there are also another fractures at the distal proximal 1/3 of the humerus shaft. And this is the full-length X-ray. From the X-ray, it's very difficult to locate the fractures, especially at the proximal humerus. So I send the CT scan. So we can locate the fracture which is happened at the surgical neck of the humerus, and the gator tuberosity is broken into many pieces, and there is no split or impression fractures at the humeral head. So the diagnosis of this case is the proximal humerus fractures T-part classification by Nears, and the fractures at the proximal 1/3 of the humerus. So after I see this case, I think of the neck shaft femur fractures at the femurs because the fracture is almost the same. The initial management, I immobilize and apply the U-slab. And the alignment after reduction is almost the same. So this is the surgical case for sure. May I have an opinion from our audience? I have two questions for you. First, if you need to fix this, if you will fix this case, you will use the single or dual implant. Who will use a single implant to fix these fractures? Please raise your hand. Who will choose dual implant? Fix it separately. Okay, for the majority, use the single implant. And the second question is, who prefer to fix this fracture with the plate? Please raise your hand. And we'll fix this fracture with the nail. Okay, thank you. So mainly we prefer to fix it with the plate. So in this case, I fixed this patient with a long Philos plate. For the intraoperative fluoroscope, I reduced the fracture first by lift the humeral head, and then I reduce the greater tuberosity to make sure that the relationship between head and the greater tuberosity is around 5 millimeters, and then I insert the plate 5 millimeters distally to the tip of tuberosity, and then I check the lateral view to make sure that the plate was located on the centers of the humeral head and on the distal center on the distal fragment. And after that, I apply the traction force and temporarily stabilize the distal part with the screw. But before I insert the screw, I also do the mini open to explore the radial nerve, because the tip of the plate might be injured to the radial nerve distally, which is passed from the posterior to the lateral edge of the supracondyle. After that, I reduce the floating fragment and then reduce the distal fragment to the plate, and then reduce the humeral head to the floating fragment, make sure that they gain the medial contact, and this is the final fixation. So this is the postoperative radiograph. This is the full-length radiographs, and this is the 7-week follow-ups. So you can see that the plate is quite long, and distal parts of the plate might be injured to the radial nerve, which is coming out, And if you want to avoid this problem, some surgeons prefer to prevent the plate distally, curve it to the anterior to prevent this problem. And you have to also have to identify the musculoskeletal nerve to prevent the injury if you prevent pre-contour the plate. And 11 weeks, the fracture is healed and the patient can move their arm nearly normal, but she complained that when she abduct the arm because the plate is too long, she requests that she want to remove the plate. So, and after 1 year, I remove the plate and the patient can use her arm nearly normal. So this is the case, and I think that we will get another opinion from our expert in this symposium. Thank you.